I would like to invite the first speaker to talk about epidemiology and diagnosis of keratoconus, what you should not miss. Dr. Nimmy J. from Government Medical College, Thrissur.
Good morning all. Today I am going to speak on the topic Epidemiology and Diagnosis of Keratoconus, what you should not miss. First of all, keratoconus is defined as a bilateral and asymmetric progressive corneal ectasia with the onset typically during the second decade of life. There has been numerous epidemiological studies to identify the incidence and prevalence of keratoconus. One of the first was by the Kennedy et al. In Minnesota, USA, and it found a prevalence of 0.054%. This was similar to the studies in Russia and Macedonia. In a study conducted by Jonas et al. In Maharashtra, India, identified a prevalence of 2.3%. A study in China found out a prevalence of 1%, and the highest recorded prevalence was by Toros Neto et al. In Riyadh, Saudi Arabia, and it showed a prevalence of 4.79%. So it is clear that there is a higher prevalence of keratoconus in Asia, especially Middle East Asia and Oceania. A recent meta-analysis was conducted among 50 million people from 15 countries, and they have found a global prevalence of 138 in 1 lakh. Now regarding the risk factors for keratoconus, as you know, the onset of keratoconus is in the late teens or in the early 20s, but modern technology has led to earlier diagnosis. It is a progressive disease and progression is seen up to 35 years of age, and it is higher in children than in adults. These are the transmission electron microscopy images of the corneal collagen bundles seen in the young and the old persons. With aging, the interfibrillar distance decreases and the collagen bundles become thicker. This in turn results in increased corneal rigidity, and thus the severity of keratoconus decreases with age. Many studies have been conducted to identify the gender preponderance. Some have shown a more of female preponderance, some more of male preponderance. The collaborative longitudinal evaluation of keratoconus KSOS study has reported a more functional discomfort in women. A recent discovery is that androgen, estrogen and progesterone receptors are present in the corneal epithelial and the stromal cells. And because of the hormonal fluctuations, the onset of keratoconus is seen towards puberty. Another time of hormonal fluctuations is the pregnancy, when there is an increase in level of the serum matrix metalloproteinase and a decrease in the tissue inhibitor of metalloproteinase, and this causes progressive corneal thinning and there is a progression of keratoconus. Keratoconus is a familial disease and the pattern is an autosomal dominant pattern, and KSOS study has shown a positive family history in 13.5% of the patients. The higher prevalence is seen in the Middle East countries because of the hot and dry climate for most parts of the year. So there is an excessive sun exposure, excessive exposure to ultraviolet light, and this results in the oxidative damage resulting in keratoconus. Frequent eye rubbing is an important preventable factor, and KSOS study has reported that 48% of the keratoconus patients rubbed both the eyes vigorously, while 2.2% rubbed only one eye. And the cases are of asymmetric keratoconus, in which the most affected eye was the one that was rubbed most vigorously. The mechanism of eye rubbing is that eye rubbing causes microtrauma to the ocular surface. This causes the epithelial and stromal cells to secrete MMP1, MMP13, and there is a release of interleukin 1, 6 and TNF-alpha. This results in the apoptosis of keratocytes, which results in the progressive loss of stromal collagen and thus results in the corneal thinning. These are the systemic associations of keratoconus, which include Down syndrome, mitral valve prolapse, connective tissue disorders like Ehlers-Danlos syndrome, Marfan syndrome, osteogenesis imperfecta. Now, taking history in a patient with keratoconus, the most important history is the frequent change in glass prescription. That is, there is a refractive instability. There is also associated allergic eye diseases like VKC, eye rubbing, systemic atopy. And family history is also important to identify formiferous keratoconus or keratoconus suspect. Other symptoms include seeing ghost images, difficulty in looking towards light, eye strain, halos, etc. On examination, the best corrected visual acuity is reduced and it may not be improved with manifest refraction, and the spectacle or the contact lens acuity may not match the pinhole acuity. It is due to the corneal irregularities. There is high myopia and also irregular astigmatism. This is the Amsler-Krumage classification, grading keratoconus into 4 stages, stage 1, 2, 3, 4, based upon the mean central keratometry value less than 48, less than 53, 53 to 55 and more than 55. It also takes into account the central corneal thickness, spherical equivalent and presence or absence of central corneal scars. The more recent classification is the ABCD system of classification. A is the anterior radius of curvature, B the posterior radius of curvature, both in the 3 mm zone centered on the thinnest location on cornea. C is the thinnest pachymetry value, and D the distance best corrected visual acuity. Now just brushing upon the clinical signs of keratoconus, it may be early and late signs. Early signs are the scissoring reflex, oil droplet reflex, Risuti sign, corneal thinning and the prominent corneal nerves. Late signs include Fleischer ring, Munson sign, Vogt striae and the corneal scarring. This is a video demonstrating the scissoring reflex. It is a very early sign of keratoconus and it is seen while doing retinoscopy. Next is the oil droplet reflex or the Charley sign. It is an annular dark shadow reflex that is observed while performing distant direct ophthalmoscopy. Next is the Risuti sign. When a torchlight is shown from the temporal aspect, we can see a conical reflection on the nasal aspect of cornea. This is one of our patients showing this clinical photograph. There is a central paracentral corneal thinning, and the thinning is maximum at the apex of the cone. Another early feature is the prominent corneal nerves. This is a Fleischer's ring, which is a late sign. There is a brownish deposition of iron in the basal epithelial cells and in the base of the cone, and it is best appreciated with the cobalt blue light. This is the Vogt striae, which is the deep stromal stress lines, which is seen in the posterior stroma, and as you can see in this video, this disappears on applying gentle pressure on the globe. Munson sign, this is also one of our patients. When the patient looks downwards, you can see a protrusion of the lower eyelid. This is a late sign. Then corneal scarring occurs when there is a rupture or break in the Descemet's membrane. Another important thing is the acute hydrops. When there is a break in the Descemet's membrane, there is leakage of aqueous and this leads to stromal edema. This acute hydrops is seen in 3% of patients with keratoconus. The patient presents with sudden onset decrease in vision, photophobia and pain. And the problem is that mostly it goes in for corneal scarring and the treatment goes in for keratoplasty. This is subclinical keratoconus. In the 50% of the clinically normal fellow eyes of patients with unilateral keratoconus have got subclinical keratoconus. They progress into keratoconus. So this is identified by using the newer imaging technologies like corneal topography and corneal tomography, and it will be dealt by Dr. Ashwati in the next session. So the take-home message is that the keratoconus prevalence is very high in our country in India, and frequent eye rubbing is an avoidable risk factor. And always suspect keratoconus when there is any refractive instability, like frequent changes of glasses, when there is history of any allergic eye diseases or family history, and carefully look for the early signs, and never miss out the late signs like Fleischer's ring, Munson sign, and Vogt striae. And early diagnosis and treatment helps to prevent progression and also going in for complications like acute hydrops. Thank you all.
Thank you, Dr. Nimmy, for that very excellent presentation. With that introduction,